Thank you everyone for coming in or coming to the presentation. My name is Galan, and we have in the house Galan Vargas. She is from Itamar, watch patch, a type of sleep test, this home sleep test that we currently use at the office, but it's very well used by other providers as well. We are going to talk about the subject for today is a guide to understanding your sleep cycles. So we have a lot of questions about sleep. I love sleep, I'm very passionate about it. And we have found ways into, to tap into all this knowledge and learn a lot of it. So I'm gonna go ahead and, okay. Anyhow, so I was born and raised in Panama, like probably a lot of you know. I went to University of Pittsburgh School of Dental Medicine and graduated, became a dentist, a full-time dentist since 2005, and I still practice in my own practice here in San Jose. I'm currently specializing in obstructive sleep apnea therapy and management. We screen a lot of patients with sleep disorder, and we complete their treatment for adults and children. We treat orthodontic clear aligner system with Candid Pro, in which we actually have Alex here today as well. I'm very obsessed with this. I've become very obsessed with it, actually, matter of fact. But most importantly, I'm very obsessed with the well-being of those around me. I'm passionate about the OSA, obstructive sleep apnea, sleep disorder breathing, and its effect on the body and overall health. Ask my family. They didn't even want to join. I think they've heard it all. I enjoy running, working out, and of course, helping others feel better about their health. Some housekeeping. We'll be taking questions at the end of the presentation, preferably, just to make sure that we don't, interrupt. Now, if the numbers stay low and we're able to be more interactive, then we can just unmute and chat and then make it more fun, I guess. Please type your name if you want, and you can put your initials on the profile so that we know who you are, or at least we can see who you are. And then please type the questions on a notebook or in the chat, and I'll be asking every so often, what you're thinking, or if you, say yes or no or whatever, so that way we kind of feel we get a survey of what's really going on. Some of the objectives for today is we're going to learn the different types of sleep tests, the home versus the polysomnograph. The home sleep test, there's several options. There's also the hybrid option, and then there's of course the polysomnograph. And so we'll discuss briefly each one of them, and then we can ask questions to Janine regarding the tests. It's the dentist's responsibility to start screening and not diagnosing some of these sleep disorder breathing issues. We're going to go over briefly again oral characteristics to recognize at home or dental visits, or what we look for when you guys come to your dental visits. We're going to look at basic interpretation of a sleep test and of course its results, and then just look at the bigger picture. What are the most important measurements to looking for sleep results? The stages of the sleep, patient cases and evaluation. We're going to look at associated conditions. And then lastly, I'm just going to give you some quick tips and some more information about how much sleep do we really need, and then some literature that I've been reading, and of course, any questions that could come up. In 2017, the American Dental Association encouraged patients to, dentists to start screening for patients with sleep disorder. That was the big turning point. It had been happening before, but it was really now led by the big American Dental Association, mother house of the whole dentist world. And so with that, a lot of us has kind of jumped in deeper into the role, and we've kind of started looking at a lot of our patients in a different way, because they truly start looking different after we start looking at a lot of this stuff. With us today again is Galan Vargas. She works for Itamar Medical. And Galan, do you want to say hi? Galan, did I lose everybody? No, everybody there?
Oh, so sorry, guys. I had to mute myself. My name is Glenine Varga. I have been in the dental sleep medicine space and in dentistry for about 25 years. I'm very proud to be working with Zoll, Itamar Medical, and offering home sleep apnea devices. I have taught for many different just teaching groups like the American Dental Association and the, American General Dental Association, the Pankey Institute, Spear, and Healthy Start, which is also for kids and airway. So I've been in this space for a while and I'm very excited, and thank you so much for inviting me on.
No, it's good to have you. You've really helped us out with a lot of this information and helped us understand really the ins and outs of these sleep studies. We're going to look now at the screening tools we use. So this is kind of what we're looking at now. When patients come into the office, we start looking at, some of the anatomy. We look at, the tonsils, the uvula. We look at the tongue. We look at the relationship of the tongue with regards to the soft palate, which is right in here. We're also looking at how narrow this distance is on top and bottom. And then, of course, how everything is coming together. And everything has its terminology. I didn't want to boggle everybody with that, but that's kind of what we're looking at. The tonsils, the uvula, the size of the tongue in relationship to the soft palate. We're also looking at imprints on the tongue. Let us know how much you're pressing up against, how much the space has been diminished. And of course, there's fissures that go right along the middle of the tongue. And then it causes just a lot of constriction. So the smaller this whole segment is, the higher the chances that you suffer from a sleep disorder. We also use some CT scans. We take some CT scans just to kind of see the relationship with, where the jaw is with regards to the upper jaw, the lower jaw with regards to the upper jaw. We look at the relationship of the neck and some of the atlas and the occipitalis area that will tell us if the patient has a lot of headaches. They can have ringing in their ears. They can have a lot of problems of many sorts. So a lot of things get pinched in this area. So the patient starts developing a lot of problems or symptoms. Here is a sample of the watch pad that we use. So we use the clinical, and we use the x-rays, and then of course we use the sleep test. And with that, we have the watch pad, and that's Janine's territory, so that we can use that to kind of marry everything together, and then we can give the patients a really good presentation about what's really going on in their mouth. So some of the definitions that we'll be looking at is very important to clarify. Apnea, one of them, which a lot of people I'm sure have heard of it, but it's a temporary cessation or pause of breathing, especially during sleep, over 10 seconds or more. So if you think about it and you actually hold your breath for 10 seconds, you start feeling like, something's gotta happen here before you start. you gotta do something like breathe, right? So oxygen is very important. Hypopnea is, of course, the abnormal, slow or shallow breathing, a pause of breathing under 10 seconds. And so there's an index that we're going to be looking at. And so that is called the apnea-hypopnea index, which is the number of times that you have a combination of things, of, either or, and it's divided by the amount of hours that your patient is sleeping. So normal sleep should have about 5 events per hour or less. The mild sleep apneas should have between 5 to 14 events per hour. The moderate sleep apnea, 15 to 29, and of course, severe, 30 plus. We also look at the respiratory disturbance index. It's a formula and it's used to measure the respiratory distress events that happen during the sleep. And unlike the AHI, this index includes the respiratory effort, which is related to the arousal. So every time the patient just wakes up, they don't have to completely wake up. They just kind of come out of the deep sleep into a light sleep. And so they're able to move or change positions so that they can actually breathe. The oxygen desaturation index is the number of times per hour of sleep that your blood oxygen will drop by a certain degree. And then the drops in oxygen levels are also called desaturations. And desaturations are more likely to occur while you're sleeping. We're also going to talk a little bit about rapid eye movement, which is your dreaming stage, and where the brain is actually pretty awake. And of course, the non-REM, non-rapid eye movement, where you're actually not dreaming at all. And it does work out, or actually does the work of weeding out and removing unnecessary neural connections. So it's kind of like a coma state, we call it. What does a sleep test do? Well, the sleep test basically tells us a lot of information regarding the position, the snoring levels, how often you wake up at nights. And again, it doesn't need to be a complete wake up, but it's just enough to get you out of that deep sleep, which is the one you really want, along with other levels. But you know, it gets you out of that, and then feeling like you need to alter your movements and to get better in your breathing. And then that shows all in your sleep pattern. The AHI, again, you know, it's the sleep apnea, 10 seconds or more, respiratory disturbance index, the partial loss of breath for about 10 seconds or longer. The ODI is your oxygen desaturation index. It's inadequate or shallow breathing episodes that lasts for about 10 seconds with at least 4% of oxygen desaturation and at least 30% of reduction in airflow. We're also gonna look at the loudness of the snoring in certain positions, and it shows also the position of the body, the sleep stages, and the oxygen saturation. And this, of course, it'll also tell us if the patient has any form of sleep, central sleep apnea. Why do we use Itamar WatchPat 1 is because they're reliable, they're recyclable. It's a one night only use. It's read by our board certified sleep physician. So we get a report immediately after we get the test back. So we encourage our patients to reach out also to their primary care physician to explore options such as the polysomnograph, which is the physician's provider's most favorite. Why do we want to evaluate the patients for sleep? Well, because there's a lot connected to it. We're finding out a lot more. So sleep is invisible times. That's why it's called a silent epidemic. And we don't know what occurs in our sleep. It's kind of on the quiet end. But as we progress through some of the different stages of our breathing, that breathing can affect our entire bodies. So the two names we're going to be looking at here, the two words we're going to be looking at is OSA, which is obstruction of the airway. It comes with snoring. And then, of course, the CSA, which is the central sleep apnea, which is when the brain does not send signals to the body while they're asleep to breathe. So basically, the brain is not telling the body, hey, breathe, breathe, breathe. So the body just stops breathing, which is pretty scary, actually. This is pretty much what a polysomnograph looks like, and this is kind of what the our WatchPat ones look like. It's evolved quite a bit. There's hybrids too, where you actually go to a doctor, they hook you up like this, and then you go home and you sleep at home. You know, you sleep in your own environment, and you get to, it's a lot more comfortable when you're in your own environment to sleep and get some better readings. But WatchPat has come up with some really good option of the WatchPat, which helps out. We use it all the time. The patients, we get some really good results and some really good readings. So basically, it's a very easy watch to use. You use it, you place it in your arm, you put it on your finger, and then you connect it to your phone, and it automatically starts reading your sleep patterns for the night. This is what a normal architecture looks like. Sleep architecture refers to the basic structural organization of a normal sleep. Each one of these segments here is a 90-minute cycle. And as you see, it starts around 11 in this case. And And so it's a 90-minute cycle. And so basically, we're gonna look at the awake, the REM, the non-REMs, which are deeper levels of sleep that we should all be hitting at certain moments in time. The first half, so how does the sleep cycles work? The first half of the night, we spend it in non-REM sleep. In the other half of the night, it's in REM sleep. So basically, this part of the night here, we spend in non-REMs. And then as the morning comes in, then you spend more time in the REM sleep. And why does nature do this back and forth within 90 minutes? Well, the theory is it is necessary to remodel and update our neural circuits and manage the limited storage space in the brain. So basically, the non-REM will transfer information to the cortex. During that time, there's transfer information from one segment of the brain to the other segment of the brain in the different non-REMs and then the REM sleeps. Our brain has to find a sweet spot between retention of new information and old information, and leaving enough room for the next day. Environmental information that comes in, you pick it up, and then everything gets changed. Everything gets transferred during the night from one segment of the brain to the other, so it filters through everything. Thank you. Here are some of the stages of non-REM. I wanted to kind of enlighten you on all this stuff. So the non-REM stage, sleep stage, starts around after the REM sleep. So you're going to drop in, and then it starts, a few minutes or a few hours after that. It lasts about 10 minutes, and you may return to it a few times overnight at different cycles. So again, you kind of drop in and come back out, and come back in and come back out. So there's a lot of movement. But it lasts about 10 minutes, right? And the amount of time you spend in the non-REM increases with age. So making it harder for you to fall asleep and stay asleep. There's a lot of insomnia that can start at that time as well. It relaxes the muscles, the body temperature begins to drop in the body, and then you have some side-to-side eye movements that's coming from the REM. The stage 2 sleep, it happens after you're fully asleep and you enter into the stage 2. It's more difficult to wake up from this sleep fully, but the brain waves will show that a certain amount of vigilance. So there is a certain brain part that is dedicated to this, which actually walls off any type of noise so that the person can stay asleep. It's actually quite interesting. If you make a loud noise or you whisper to someone during this phase, it'll pick up the noise, but it will be blocked to a certain point that it doesn't awaken the person. The non-REM 2 lasts about 10 to 25 minutes. And this phase is categorized by the lack of movement. So patients very still, a continued drop in temperature, more regular breathing and heart rates, and just a very rapid brain activity that indicates that the brain is starting to organize the information and starts transferring over to the other side, to the cortex, to start storing the memories in a more safe place. 3 and 4, at the base of this graph right here, these are all deep sleep, slow waves, which is really hard to awaken the person. It is essential for restorative sleep, regenerative sleep, and when your body repairs itself and allows you to awaken feeling refreshed. So basically, this is where you're going to get that cleansing face or cleansing look that people that have a nice sleep will have. Non-REM 3 will also appear to be, it's important for memory and creativity, and you spend more time in this phase in the early part of the night, and it lasts about 40 minutes. What it does is it increases relaxation and decreases pulse and breathing rates. Blood flow to the brain releases growth hormones, which I found this to be very interesting. It releases, this is the point where the growth hormone is released, and so the kids start growing. So sometimes when you start treating kids, you start placing them on appliances or braces or whatever, and they start, the more you expand, the more air they start getting, the faster they're going to grow. Oops, sorry. And then, so I thought, again, this was a very interesting information. The REM sleep, rapid eye movement, deepest state of the sleep, and is when you have the most vivid dreams. So the non-REM sleep is when the body is restored, and experts believe that the REM sleep is is when the brain is restored and prepared for the next day. There's about a lot of muscle immobility, increased breathing rates, heart rates, blood pressure, body temperature increases, a lot of eye movement. Probably you've heard a lot of that fast eye movement, increased brain activity, which REM sleep and complete awakeness of the person is pretty much the same when you look at it in the graphs. The biggest difference is the immobility of the person. So that's how you can tell. And that works the same with insects. Say, for example, they don't move. It's probably because they're sleeping. Good time to catch them, I guess, right? Anyhow, so we're going to start with patient number 1. This particular patient complains where he was dozing off at work. He would doze off while driving. He was tired upon waking. He had venous pooling, meaning dark circles under their eyes, anxiety at social settings, mild depressive episodes, and irritability and moodiness. This is his chart. We're looking at the time that was recorded to the time of the sleep time. And so there's a bit of a difference here, and this is where Glenine is going to come in and just really break it down for us at times.
Yes, I would love to. You just let me know when you're ready.
Okay, go ahead.
Awesome. Okay, so great job putting that information together. There have been some changes in regards to the sleep stages and the information, but I'll kind of go through that here. What's really nice is that, this patient, they recorded 6 hours and 46 minutes. So if we go off of what you said we need to have like 5 90-minute cycles. So if we do the math on that, 5 90-minute cycles is 7.5 hours. And then it's going to take us like 15 minutes or something to fall asleep usually. So we should try to be recording a good 7 hours and 45 minutes, something like that. So for this patient, we can see immediately in regards to sleep hygiene that they're just, that 11:29 bedtime, that might be a little late for this person. They may want to try to go to bed at 10 instead and get that extra 90 minutes to be able to get that better sleep. So we see that he recorded 6 hours, 46 minutes, but only slept for 5 hours and 56 minutes. So that's one of the awesome things about the watch pad is that we are recording true sleep time. So we can see exactly when the patient is asleep and when they're awake and evaluate that information. It's different than other devices because a lot of devices don't really know if the patient's asleep. They just know if the patient is breathing or not. And so ours is a lot more accurate, if you will. Now, if you look below that, you can see that this patient got 21.5% REM sleep. And so what Dr. Galan was explaining that in REM, we are dreaming. And so we have rapid eye movement. So our eyes are moving everywhere, but our body is paralyzed. We can't move. If anybody has ever woke up in the dreaming cycle, it feels like you're being pinned down, like you can't raise your arms or your legs or anything. That's called sleep paralysis. So we can see that this patient gets a good percent of REM at 21%. And if we look down, we can see that this person got 85 events where their sleep breathing interrupted their sleep. And like Dr. Galan explained, doesn't necessarily mean they woke up 85 times. It means that they had 85 arousals in their sleep that interrupted their sleep. And so out of those 85 arousals, looks like there's 19 apneic events out of those 85. So what we mean by apneic is that the patient stopped breathing for at least 10 seconds or longer with a drop in their oxygen saturation of at least 3%. So we don't take the total events and that's our number. What happens is we take the total events and then we divide it by the hours slept. So if you look at the 85 events divided by 6, that comes out to be 15.2 events per hour. And then if we look right below that, the apnea number, which means the patient stopped breathing completely, that divided out to be 3.4 per hour. So what's very important for us to understand is that we can see these numbers. And Dr. Galan explained to us that anything over 5 may be considered apnea when working with a board certified sleep physician. And so we can see that this patient, coming from a dental perspective in a dental profession, we cannot make a diagnosis, right? So we have to work with these physicians. But the physician may say, you know, that may not be apnea simply because that AHI number is not over 5.
Right.
But what's really nice to see is that with the watch pat, if you look over to the left, you can see what this patient's number was during REM when they were paralyzed and dreaming. And you can see that that number is elevated versus the time when they were not in REM. So, you know, again, coming from a dental perspective, one of the things that we really like to focus on and make sure that our patients understand is that even though they have, you know, 15.2 interruptions in their sleep per hour due to their breathing, and it may not be diagnosed as apnea, but this patient has up to 15 times their sleep is being interrupted. You know, that's a lot per hour. That's like somebody coming in and tapping on your shoulder going, hey, hey, hey. And, you know, it's a lot of arousals. And if you look at the time in REM, those arousals increase, you know, all the way up to 23.9 per hour. So that's kind of, you know, that's, we don't like to be interrupted that much. But when we look at the straight oxygen, and this is something that I just wanted to make a little correction on what you had said before, Dr. Galan, on the ODI, the oxygen desaturation index. If we look up on the upper right corner of this first page, we see that this patient's maximum oxygen level is at 98%. So that means if their oxygen drops by 4%, even if it's just for a second, it doesn't need to be 10 seconds. It could just be a quick drop. If it drops, then that's when it gets calculated as an event. So this patient had 3 events where their oxygen did drop by 4%, but when calculated over the hours slept, it's only 0.0 or 0.5 per hour. So, you know, again, we are not physicians, and the physicians are the ones to make this diagnosis and determination. But we would see patients that are more sick. They have more comorbid situations if they have a lot of their oxygen is depleting. And so this person may not be struggling so much. Now, the other thing that we've got with the watch pat, did you want to say something, Dr. Galan?
Yeah, so one of the things that, you know, I've heard a lot is, you know, back to the AHI, basically you look at this and the doctor says, oh yeah, you really don't have any problems here. Yet all the symptoms of the patient are, you know, I fall asleep when I'm driving, I may be depressed, I have issues staying up at work, I have some problems with insomnia to a certain degree, or so we don't just look at the numbers, we look a lot at the symptomology of the patients, right? Because that's the real deal. When the patients start feeling better, they're the first ones to know and the first ones to tell you, hey, I'm feeling a lot better. So
you're absolutely correct. And the other thing to just understand is that this is one night. Right? One night out of all of the nights that we live on this planet. And so, you know, if we drink alcohol, if we, you know, take a sedative, if, you know, there's going to be different things that impact these numbers. So Dr. Galan is so right. You've got to be able to, if you're a patient, you have symptoms and issues like we saw on the first page, you've got to be able to discuss this with your dentist or with Dr. Galan so that she can evaluate all of this and how it all comes together.
Right.
So I love that. So what I really want to point out with the watch pad is if you look below all the numbers up on the top, we've got 4 bars of information. It's really 5 bars of information. And this what's nice about the watch pad is it's recording all of this information simultaneously throughout the night. And this is what's different than any other sleep test out there, because most of them, again, are going to be measuring breathing and not necessarily sleep staging and everything else that's going on. So I like to focus on the bottom. If you look right down at the bottom and you see the wake sleep stages, and there's a time bar underneath that. Now you probably can't see it because it's too little, but that time bar is showing us all the time throughout the night. So we can see that the patient turned on the device and they probably had it on for about 15 minutes, went into light sleep, and then got into deep sleep and was like, great, but then something woke them up. You see that right there? They're deep sleep right there, and then something woke them up. And you can see if you look right above that, the red little lines, the squiggly lines right above that, that's the heart rate. So you can see that the heart shot up really high when the patient woke up at that point. And then you can see that as the patient cycles throughout the night, the heart is reacting in different ways based off of what sleep stage the patient is in. So if we kind of looked at Dr. Galan's ideal sleep structure, we could point out that this patient had 1, 2, 3, 4, 5 deep sleep cycles. But all of those deep sleep cycles were interrupted at some point. There weren't good chunks of deep sleep like we saw in her ideal sleep structure pattern. So we may, be, evaluating that and in determining that, if that RDI, that respiratory disturbance index, all of those events that are occurring could be interrupting those sleep cycles. But again, we've got to work with the physicians to make that diagnosis. But these are things that are nice to be able to see from a dental perspective and from a patient, just to understand how it all works. So as we look at that snoring body position, which is, you're going straight up to the red squiggly lines, which is the heart rate. Right above that is the oxygen level. So we want our patients to stay above 90 all night long. And this person does. They don't really drop down below 90. And you can see that up on the very top graph. It says the minimum oxygen level is 91. So we don't want patients to be below 90. So we should be good here. I just had a question. Does WatchPat measure HRV? We don't measure the actual HRV, but we do monitor the pulse rate all night long. And you can see that pulse rate where the minimum is 55 and then the maximum is 97. So we're plotting out every single heart rate that is occurring down there in that red oxygen saturation index section. So hopefully that answered your question. As we look over to page 2 of this study, what's phenomenal here is we can see that really, this patient spends most of their time on their back, 82% of the time on their back, and only 17% of the time on their left side. They don't sleep on their stomach. They don't sleep on their right side. And when you look at those RDI numbers across the board and the AHI numbers, they're almost the same, 15.3, 14.6. So what that's telling us is it doesn't matter what position the patient is sleeping in, their airway is still getting impacted. And so, these are things to point out to them, especially when they're going into REM and they're losing that muscle tone, that those numbers are getting worse. So if we look down at the bottom, what we see there is we see the sleep efficiency right down on the bottom on the sleep-wake stages. And it shows that the patient was awake for 87% of the night. They were asleep for 87% of the night and they were awake 12% of the night. And you can see that down there in that nice little pie chart. And then over to the right, what we see is it takes all the different sleep stages the patient has and it graphs it into a nice little pie chart. In an ideal, perfect world, we'd be getting 50% of that light sleep. Dr. Galan talked to us about that, where our muscle tone is like, we're losing that muscle tone. And then we would ideally love to get 20 to 25% deep sleep and then 20 to 25% REM. Now, what's awesome about deep sleep, and it kind of talks to your point that you made up earlier regarding the Parkinson's disease study, is that we just discovered that in deep sleep, we actually clean our brain. So it's called the glymphatic system. And so when we're done with this, you guys should go look it up, pop it in. This was just like the lymphatic system, except you put a G in front of it. So just think about me. That's my nickname, is G. So G in front of the lymphatic system. And what that does is that when you get into that deep sleep, which Dr. Galan explained, that's the delta brain waves, our brain cells shrink. They shrink to allow the cerebral spinal fluid and blood to flow through our brain and clean out the beta amyloid protein that is built up throughout the day. And so when you have patients that are wanting to evaluate their sleep, it's such a good thing for you to be able to see how much deep sleep they're getting, for you to be able to help them, see if, are you getting any, or is your deep sleep getting interrupted a lot? And that's kind of what we see in this one. So I don't want to take up all the night talking about this study because I know we have another one to look at, but that's pretty much what the watchpad is showing you here.
No, that was great, Glenn. That was a great explanation of the whole thing, because it is true. I mean, we can see really well, and this patient in particular, I mean, he's pretty well distributed, if you will, right? But then all of a sudden you look at all the other symptomology that comes along. And by the way, that patient's doing really well. He's actually sleeping the entire night. He's gotten 200% better than what he used to. So he's not falling asleep at work, and definitely not on the wheel. So we're
I can't wait to see his sleep test once he's, you know, in the appliance to see and be able to compare the difference.
Test on him, yeah, and compare and contrast, absolutely. This was his airway, so I'm going to move on to the next slide, which is just showing the X-ray part. So, you know, here you can see the front to back pressure of the tongue up against the back of the throat, and of course how that compresses up against the back of the, you know, the oropharyngeal spaces. So basically this patient is getting trapped in this segment right here. As it travels down behind the tongue, then it's opening up a bit more, which is great. And then, you know, again, this segment here is the part that we need to work on. So with the appliances that he's been wearing, we've been able to expand the arches. So as you see here, you have constriction side to side, right? So as we expand the arches with the appliances, we're able to allow more room for the tongue to set and for things to just kind of open up for him as well. This is a report that we get from the sleep doctor. So in it, it says, you know, the patient is symptomatic for upper airway respiratory syndrome. So UARS is a very common term, and you know, it's not apnea, it's just like there's just constriction on the upper airway that needs to be addressed, you know. And then of course they go into all the details. ENT consultations, malfunction therapy will help. We haven't gotten into that, but we're going to have hopefully somebody coming in and talking about that as well, and what the exercises look like and what exactly it does. So stay tuned for that. But orthodontic treatment, they recommend weight loss. You know, males carry the weight up above the waist and females the opposite, right? So males tend to get more constricted up in the area, and the snoring and everything happens a little bit faster with them because of that. And then females kind of hide it a little bit more. And the thin faces and everything just kind of, you know, also constricts the airway by creating more upper airway respiratory. So females suffer more of upper airway in the general sense of things, really. Here we go, patient number 2. So we picked these 2 patients because the patient number 1 and the patient number 2, it's like a mini me. So patient number 1 is a mini me of patient number 2. Okay, so here we go. It's CPAP wearer. He has severe sleep apnea. He suffers from daytime sleepiness. He got tired of the CPAP. He wants to get out of it. So he really just wanted to do something about it. He's been wearing a CPAP for 5 years or so. So anyhow, so he heard about the therapy, and of course he felt like he wanted to see if he could get some resolution for this.
And we probably just have to switch this picture at some point because that was a different study.
Well, the funny thing,
this is it. This is the severe one. I got it.
Yeah, this is the same. This is the patient. So we go through again what Janine explained to us before about the RDI, the resting disturbance index, and how it actually gets, you know, shifted while they're sleeping. They move around, and of course the apnea hypopnea index. You know, again, now he's falling in the 40s, right? So he's up here. The last patient was down here, okay, in the green. And then of course here we have the distribution of the deep sleep, the REM sleep, the light sleep. Then again, look at the distribution now that we have a little bit more knowledge of what it should be looking like. So he's not going into the deep sleep as much, right? We're also looking at the different positions of the body, and then of course, you know, what each one and how each one. So this is a right, the other one was a left, but here we are, right, with the numbers. So they're pretty high.
So the big thing to look at this with Dr. Galan is look at all that blue that's in there, and then look at that black, the oxygen saturation, how much it drops past the 90 that we don't want them to be dropping at.
Exactly.
And so, and then if you look, most of those really low drops are during REM, during when that patient is paralyzed.
Right. So one of the things that I know that we've discussed with Janine is these little lines right here, these individual lines right here show the one event of holding their breath, right? Janine, they just hold their breath for that one event. And then every time that you compact these blue lights like that, that's just how many times in that particular time that patient keeps holding their breath. So just imagine this gentleman here. Look at this. Now with that information, you can just see how long he has been holding his breath. Isn't that crazy?
A lot.
That's
Poor
a
guy.
lot. Like, that's a lot. Look at, and he says it's sleeping, right? So he's sleeping here, right? And he's awake a little bit, but it's just the amount of oxygen deprivation that this gentleman is going through. It's crazy. We also look at the spikes of the oxygen, right? So again, as you see this cumulative events of respiratory events, then we are severely dropping the oxygenation, see? So the minimum oxygenation here was 74. That's crazy. I mean, if you hold your breath for, I don't even know how long you can hold your breath for that amount of time to get it to 74. And when we talk about this is, you know, that little pulse oximeter that you guys wear when you go to the physician's office, that usually comes up with like 98, 99. So that's what they're measuring. They want to know at the most outermost extremity, how much oxygen you're getting to that furthermost part of your body. And in this part right here, he's actually getting 74%. Okay, so I have a question. Says when I was studying psychology, it was to my understanding that we slept 2 cycles throughout the night, and each cycle was 4 hours. Glennie, you want to take that?
You know, I would just, I would refer back to Stanford. Most of all the information I get from is from Stanford, and, looking online, that's where we got that from. I would tell you this though, and studying psychology, I would tell you that most people, they don't do the ideal sleep structure. Most people, we do not get 5 90-minute cycles of sleep, and we do not go through those sleep cycles the way we should be doing it ideally. And that's the issue, is that we've got a lot of interruptions and a lot of things that are causing these sleep cycles not to be what we would ideally like to see. But the other thing that's really interesting is that we're just finding out this stuff about sleep. Like, we're just starting to study this. So it is absolutely so possible that, we're going to find out things as we go along in the future about the way that we sleep that we didn't even know that, just like with the whole lymphatic system thing. So, it's
with the Parkinson's information that Dr. Najwa shared with us earlier on. So, there's just so much being uncovered. I had a patient yesterday. She was trying to lose weight. She couldn't lose the weight. She was in some, weight loss program at Apple, and she just was getting frustrated. The internal medicine doctor talked to her and she's like, well, what's going on? What are you doing? Blah, blah, blah. She's like, you know what? Let's test you for a sleep disorder. I think you have sleep apnea. And sure enough, she's a mild sleep apnea case. All these things, and we'll go on to that later, but all these things are part of the sleep apnea, believe it or not. So there's a lot more tied to the sleep than we all know about.
Exactly.
So anyhow.
Wow, Dr. Galan.
Yeah.
I would be remiss if I did not point out this point. You guys, look at the body position. Look at the body position here on page 2, where it shows the supine versus any of the other positions. So this patient spent 402 minutes on their back. That's what supine means, which was 87% of the night. So the majority of the night they were on their back. Look at those RDI, AHI, and ODI numbers. They are very high. If you look at the right side, the patient only slept on the right side for 12% of the night, which was 58 minutes. But those numbers are like really low. So this tells us that the body position is a huge determinant to this patient's numbers. And this is a big thing for Dr. Galan to know, because as a dentist treating, or helping to maintain obstructive sleep apnea, having an oral appliance that brings that jaw forward, you're going to be mimicking that patient sleeping on that right side, possibly. And you're going to be reducing those numbers quite a bit. So this
Absolutely.
that's a big point to make out to your patients,
Yeah.
because this person, you could see they just, on that second graph there on the left where the orange and black line, they slept on their back the majority of their night, except for that little chunk there. And you can see in that little chunk there weren't a lot of respiratory events occurring, and the patient actually hit REM. They were paralyzed at some point. So this is a huge point for Dr. Galan, because she may be able to accomplish these very low numbers that the patient is reaching when they sleep on their right side, when she's had an oral appliance in their mouth. So it's just something to consider.
Oh, that's a great point. Yeah. And then we also sometimes see a lot of clinical manifestations. We see cavities, we'll see more wears, we see more recession, we see more, I mean, we haven't even started looking at the oral part of everything, right? And we start seeing a lot of that. So we almost can kind of read the patient while they're in the chair with some of this information. You're like, okay, do you sleep more on the right, do you sleep more on the left? That kind of thing too. So it's,
you bring up such a great point, because we focus a lot on the oral appliances bringing that jaw forward, but there's so many other things, like you just mentioned, the soft tissue, the anatomy, and there may be things like myofunctional therapy or other things that you can be working with to help reduce those numbers. So very good point.
Right. And then of course this is his CT scan, and his CT scan, if you look at it, it doesn't really look that bad, right? You can't imagine this person being like a severe sleep apnea case, right? You look at it and you go, really? It doesn't look so bad. But again, that in combination with the sleep test, in combination with the
because we all have a wonderful open airway when we're awake and upright. I mean, we don't snore when we're during the day, but moment you put this person back on their back and then they go into REM, it's gone. That whole nice, beautiful airway you see here is not the same airway at night when they're sleeping.
Absolutely not. Absolutely not. So, so this, so what we were thinking here at the office between those two patients is that if this patient, the first patient, would have not been treated with appliances and stuff that we're doing at the moment to correct early on that sleep apnea, this patient would have probably been this second patient 20 years from now, which is really just interesting to see, right? So they look very much alike height-wise, structure, body type, et cetera, and even in some of this, it's just slightly a little bit more yellow. But the reality of it is it would have been something similar to this at that age.
And Dr. Galan, can you tell us about the age difference between the two? I saw the first study was 24 years old, but I didn't see the first page.
It's about 20 years. So
the 20 years difference. Okay.
So it's about 20-year difference. Let's see.
Okay. Yeah. No worries. I was just curious. So just think of this, if you let that 20-year-old, the 24-year-old, if you let the 24-year-old go, right, for 20 years, yes, I agree with you, Dr. Galan. It is very possible that patient may end up here. And if you're gaining that weight and you're not able to lose it, there's going to be a host of comorbid, things that are occurring. And that's when we talked about that. We talked about the ODI. If that ODI is high, if that patient has a lot of oxygen drops at 4%, they're probably going to have a lot more comorbid, issues and problems.
Exactly.
Diabetes, high blood pressure, and exactly. So, you're helping this 24-year-old hopefully not go down the route of this.
And this is, just so that everybody knows, there's a lot of parts attached to this. This is just the tip of the iceberg that we're just touching. I felt like it was important to understand at least what a sleep study looks like, what we're looking for, and how to interpret some of this. Anyhow, so this is, again, so the difference is almost exactly 20 years, just so you know.
Wow.
The patient is wearing the CPAP, so obviously, this is something that he's continuously using it, although now he's dropping a little bit more. I've had patients that are completely out of the CPAP now with appliances, so they're actually doing really, really well. ENT, myofunctional therapy, we will talk about that another time. Of course, weight loss programs, especially males carry their weight higher, so anyhow, so that causes a lot of constriction as well. So some of the associated symptoms are insomnia. Other problems are insomnia, narcolepsy, sleep apnea, obviously, depression, schizophrenia. All these type of conditions can arise from problems with a sleep disorder. You know, and then we go here into which one is which, moving from the REM2, now that you know the sleep stages, right? So you know that the sleep stage is now the 4, so the 3 to the 2, and so the insomnia will move you up to a non-REM 1 or higher. So that means that that person can never drop into that sleep. So they wake up and they're like, oh my gosh, I can't sleep. I'm awake all night long. Why? Well, this is why you're having these problems. Narcolepsy REM sleep is reached much more quickly than usual, and possibly depriving the body of important restorative phases. There's a speaker that I've actually want to contact regarding narcolepsy. She suffered from that. She's from, I think it's Stanford as well, and she has a book about it and a really interesting story about her narcolepsy. But sleep apnea cases, you know, obviously the pausing and the breathing, and then depression. There's less time, you know, appears to be spent in the non-REM sleep. So depression is very linked to your non-REM sleep drop 3, right? So we haven't touched the 4 yet. We're just at the 3 level, which you're really deep into the sleep, almost like a coma, you know, comatose state. And then the REM sleep may be reached earlier than this is typical. So obviously, right? So the shallower you are in that deep sleep, the quicker you can get to that dreaming state. So, you know, that's probably one of the reasons why a lot of patients, you tell, well, you know, how's your sleep? Oh, I sleep just fine, of course, because they're sleeping and they're in REM sleep all the time, right? So they really just don't know. They're like, I'm dreaming. You know, that's what sleeping is all about. But that's really not what sleeping is about. And in schizophrenia, obviously less time appears to be spent in non-REM phases, especially in non-REM 3. And then the REM sleep, again, is reached a lot earlier. And this could be due to high rates of depression in people with schizophrenia. How much sleep do we need? A lot of people ask that question all the time. So here it is. We have infants need about 16 hours a day. Obviously, everything's broken into age groups, right? So the toddlers and preschoolers, they need about 12 hours a day. Teenagers, those are tough. I have one at home. They need about 9 hours of sleep. There's a lot of sleep hygiene attached to that. So, you know, that can go another time too. Adults need about 7 to 8 hours of sleep. Some of them need a little bit more, right? And of course, pregnant patients may need a little bit more sleep, especially during their first trimester. And if the person's suffering from a sleep disorder and now we're having a baby, so that compresses the diaphragm, it compresses breathing, it restricts everything. The patient can suffer from blood pressure problems and on and on and on. So it's very important. And then the baby too, right? They start getting depleted with oxygen. And so then it comes up with, like, you know, early deliveries and, you know, on and on. So I'll give you some insight as to where I'm getting this information. This is where I'm getting all the information. So Dr. Matthew Walker, big promoter of sleep, very famous neuro researcher. And he says, scientists have discovered a revolutionary new treatment that makes you live longer. It enhances your memory. It makes you more creative. It makes you more attractive. It keeps you slim and it lowers your food cravings. It protects you from cancer and dementia. It wards off colds and flu. It lowers your risk of heart attacks and strokes, and not to mention diabetes. You will feel happier, less depressed, and less anxious. Are you interested to know what it is? And here is the book. Okay, so for Jermaine, I believe his name is Jermaine, it was asking me the question about, you know, the 20% and all that good stuff. This is a really good source of information. I would strongly recommend you reading this book. It's very detailed. So, you know, I've actually, I have it around here somewhere. I've actually I was taking my time reading it because I have to dissect every single bit of it. And it's very interesting. So this is a really good source. And that is it. Not sure if anybody has any questions about anything. We'll be more than happy to answer that. Yeah, just let me know, and Janina, I can answer anybody's concerns or questions.
So Dr. Galan, if anybody does have any issues, do they just call the office and schedule like an evaluation with you?
Yes, they could do that for sure. Yeah, we'd be more than happy to help.
Yay.
Yeah.
So I have a question.
Sure.
And it's not only about how you deal with it, but also any adjunct services that you give or refer out for, because from my readings recently is that a lot of it is, of course, as we know, it is a lot of constrictions of, in the position of the maxilla and the mandible, and we need to expand and bring forward and all that. But also, as I was doing more research, it has a lot to do with our autonomic nervous system.
Yes.
So the malfunction of our autonomic nervous system. And it's funny, I was reading through that actually today, and I came across one reason to why some people have rhinorrhea, which is dripping of the nose, especially when they eat. And my father is one of them, and he's 99 years old, but he's been complaining of that for 20 years. And I had no idea what it was until today, that it is actually a disruption of the autonomic nervous system. So your voice, we can't hear you. Susan?
Oh, I think she was saying goodbye. Oh,
yeah.
but I agree with you completely. And it's really interesting that you brought that up, because the way that the watch pat works, you put the probe onto the finger. What it's doing is it's picking up on the peripheral arterial tonometry. So what it's doing is it's a reflection of the sympathetic nervous response. So when a patient goes into fight or flight, which is oxidative stress, then that's when the blood flows away from their fingers and toes and goes to their heart and their brain to feed those organs more oxygen. And so that's what's awesome about the watch pat is we are recording every event where that blood flow exchange occurs on top of the 6 other channels of information. So that's exactly how we can determine, is someone like your father having an arousal in their sleep? Is it because of sleep? Is it because of breathing? Or is it because of something else? And so we're able to tell that. And that really helps with the algorithm of telling between obstructive apnea or central apnea, where the brain is involved as well. So that's a great point that you bring up. And yeah, you're absolutely right.
Yeah.
So question now with this appliance, because I had never heard of it. So I'm so glad I joined you guys today. So now I'm in New Jersey, and in New Jersey, I cannot prescribe a sleep test. I know I can use it as a screening agent. Okay. So now how does it work exactly? So when I get, let's say I get the appliance, it is a disposable, but not the whole appliance, right? It's in
So
the whole,
if you were to get a watch pat one, it is fully disposable. So your patient would take it home and wear it, and then they would either throw it away or send it back to our company, which we pay for recycling.
Oh, okay. That's cool to know.
Yeah.
All right, very good. So if I am to purchase one, it will be through you?
Yes, you can purchase through us. You can come directly to Zoll, Itamar Medical. There's 3 of us on the dental team. And so, yeah, you can reach out to us and we can get you going. We always, when we sell the watch pat ones, they always come in a box of 12. So we never sell one individually. And then, of course, our recommendation is, and no matter what state you are, if you're a dentist, you absolutely want to reach out to the physicians in your area, because you can develop a referral system. If you've got patients that need to get diagnosed, you can, work with them to be able to diagnose with them. And then who knows, they may have a watch pat. So it would be really nice to be able to compare the information together.
Well, that's true. So I do actually, that's how I do it. I send my patients back to their physician or to an ENT, someone who is willing actually to give a sleep test.
That's so wonderful. And we have a really cool app that's part of the Watch Pat One app that allows for a patient to fill out a questionnaire as a screener, so they can do that in your dental practice, and then be able to, if let's say your physician was using Watch Pat, then you would be able to get that screener form to that treating physician, and that physician would then be able to see the patient and order a Watch Pat on their own that doesn't have anything to do with you, and let that patient get diagnosed with the medical side, and then be able to come back to see you for therapy if it is appropriate.
Okay, but I still can do it as a screening myself.
Of course.
I mean, how much does the appliance?
I think, of course, I really don't know the dental state board rules, so that's definitely something that you would want to find out and clarify.
Oh, yes, yes, of course. I mean, screening, it will be just for me. I don't have to even tell the patient if I want to,
There you go.
Yeah.
Well, thank you all for
Oh, thank
joining.
you.
This is a great time, Dr. Galan. Thank you.
Yeah, thank you.
Yeah.
Anybody has any more questions?
Aida, you did great.
Oh, thank
Good
you.
job.
Thank you. Thank
The
you.
next one now.
Thank you. Thank you.
No more questions, but I just want to say thanks. There's a lot of great information. Been learning about more airway over the last 6-7 months. And I think everyone should get a sleep test because
I
you
agree.
never know what's happening when you're sleeping. I had doctors ask me about me and I would say, oh, I sleep pretty good. They're like, well, how do you know you're asleep? And
Exactly.
I got a sleep test done. It was just a one-night one, probably 3 weeks ago. And it showed that I had mild sleep apnea. Now, there were some things that happened that I didn't realize. I had 23, I think, arousals during the night. I don't remember waking up that many times, right? And then I also had my heart rate go up to like 120 at some point during the night. And I stopped breathing for 30 seconds at one point. Now, if I were to hold my breath for 30 seconds right now, that seems like a very long time. And so it only happens one time.
It's scary. It's a scary long time.
Yeah. And one thing that was interesting too that you mentioned on here was about sleep paralysis. I get it about once a month, but that night it happened twice, and it usually happens when I'm on my back. So you're talking about the positioning. Maybe it's because I'm on my back, my tongue rolls back more than I'm normally a side sleeper, so I usually don't get it. But if I'm really tired and I end up rolling on my back, I get that sleep paralysis. So I have a friend I was talking to today, and he says he's always tired and he falls asleep randomly. And I was like, you know what, this actually sounds very familiar from what I've been hearing, the last 6 months or so. I was like, maybe you should go take a sleep test. I actually invited him to this tonight. He wasn't able to make it because he has work, but I'm gonna try my best to get him into your office, Dr. Galan. So we'll see.
Sure, I'd be happy to take a look at it.
Alex,
Yeah.
I would suggest the sleep test, get the CBCT done.
Yeah, I got a CBCT done as well. And nothing was alarming there. It was normal, but yeah.
Yeah, and it happens. It just basically means that you're waking up during REM. You're in REM, you're in a dream, you're paralyzed, you're dreaming, and then for whatever reason you wake up during that time, but your body hasn't yet woken up to where your brain is woken up. So you do feel that paralysis, like somebody's holding you down or you can't move, or and after a few seconds, minutes, it starts to come back, and then you're good to go.
Yeah,
but that's
it'll definitely come back. Yeah, it's just a matter of time at that point. So don't forget, I had another patient that told me the same thing the other day. She says, oh, is this when you wake up? And I've woken up a couple of times, same thing, I've just frozen. I'm like, yep, that's the atonic state that you're in. You just didn't come out 100% out of it, and you're just kind of frozen. So it's interesting. It's very interesting.
So I have a walk the wall question, but Alex, just the Candid Pro, do you guys offer sleep appliances, or are they mostly clear aligners and expanders?
Yeah, so they're clear aligners and it's just clear aligners, but we have two different protocols. So we have like a regular Candid, or we have a Candid RX protocol, which will just align the teeth in a normal way as any other aligner company would. We focus on expansion, and we don't do any IPR as of yet, so we don't shave any of the teeth. But we also, we're partnered with Airway. We have a Airway protocol, where we don't retract any of the teeth, and we focus on expanding the intermolar distance. We try to get to like 38 millimeters depending on the patient. So we want to make as much room for the tongue as possible, and we won't retract the front 6. So we leave as much room as possible. So there's different protocols that we use, and we partner with a lot of different airway doctors. This is how I know Dr. Galan, and I also have Dr. Bong in here. She's in San Francisco. She does airway as well. And so I've been learning a lot about it over the last 6 months. And so it's super interesting to continue to learn, and why I wanted to be here tonight.
Awesome.
I love Candid Pro, actually.
I need to learn more about it. I've been in here and I never even heard of it. So I got to learn more.
It's actually very interesting because the way they do the expansion, it's also putting pressure on lingual of the teeth, but not the teeth only. So the trays go, the aligners, they go a little deeper, so higher up on the maxilla, on the ridge, and lower on the mandible on the ridge. So it puts pressure, and that pressure stimulates osteoclastic formation. So
Exactly.
I love it. I thought I heard somebody say a question or something.
Yeah, my name is Martha. I am one of Dr. Galan's patients, and I started the Vivos appliance about 2 years ago, and I have been so grateful because it's really, really, really working for me, and it's really changed my breathing, my sleep, and I'm not quite done. I still have about a year left to go. And I just wanted to mention that because I think it's important to know that, you know, I'm I'm proof that this works.
You're a rock star, Martha. It's a lot.
We had our Vivos representative. She tried to get in. For some reason, she couldn't get in. I'm not sure what happened. She was texting us and calling us here. So anyhow, but yeah, Martha is she's been quite the patient, and she has been so disciplined, and she does exactly what we're asking, and she has come around so much. And she's dropped from, I can't remember what her measurements were before, but she came from severe sleep apnea to hardly anything, right? Right, Marta? I can't remember your numbers at the top of my head, but
Yeah, that's correct. My
Yeah.
airwaves were really restricted.
she's lost about 50 pounds, and she's another person. She's just a completely another, physically, she's another person.
So Dr. Galan, with Vivos, it's expanding the upper arch. And then does she also wear a lower appliance at night? So when she's
Correct.
sleeping to keep that airway. So that's wonderful. So it's like oral appliance therapy with expansion at the same time, correct?
Correct.
Awesome.
Yeah, and then we have hooks. We have hooks, like there's some patients, for example, have a case going that she has implants in the front teeth. And so we can't, thank you, and we can't really touch the anterior portion of it. So what will happen is that we create, this is the appliance, I don't know if you can see it. It kind of looks like this. Anyhow, so yeah, so we actually create some hooks, and we try to bring the maxilla forward a little bit so that we actually can, you know, get a little bit more room front to back, right?
With a face mask.
We gotta go front to back and then side to side.
With a face
Wonderful.
mask, yes.
Martha, I'm so happy for you. Great job.
Thank you, Martha, for joining us.
Yes, congratulations, Martha. That's great.
Thank you.
Yes, she's come a long ways.
It's so
anyhow,
gratifying, right? When patients
Sorry?
tell you that they breathe so much better. I love it when the spouses come to me and say, oh my God, we're sleeping now.
Well, my whole family's in it. My husband's got it. My son's been wearing it, and I've noticed
I did
tremendous
too.
improvement on both of them. Yeah. So it's been great to be able to open up the airway, and I mean it's just, you know, if I can, you know, start working with my family on all of this, my friends, my staff, you know, again, like Alex said, this is something that everybody should do as part of their physical. Everybody should have a sleep test.
Yeah.
Strongly encourage you to do that. So anyhow, all right, everybody. Well,
Thank you so much.
thank you very much for joining us, Dr. Nashua. I know it's kind of late over there, but
No worry. It's my pleasure.
you're
My
a night
daughter's
owl.
waiting for me to get some
But,
classes registered now.
yeah, well, thank you so much for joining us. I appreciate your time, your feedback. Lane, thank you
Oh,
so
no,
much for all
thank
your
you.
information.
That
And
was great information. Thank you, Aida.
yes, you're very welcome, doctor.
Good night,
And,
everyone. Very nice meeting you.
Yeah,
Yeah.
nice to meet
Bye-bye.
everybody. Thank you. I
Yeah.
see friends and family and patients online, so thank you very much, everybody, for coming in and joining us tonight.
Bye-bye.
Bye-bye.
Great job, Dr. Galan. Thank you.